what are the next steps towards reuniting families in our long-term care facilities and with their loved ones across the state. What is the plan for reopening our senior living homes, lifting the restrictive policies in nursing homes and assisted living? Grandparents want to be able to hug their grandkids. Children want to spend Easter with their parents, and friends want to start to visit friends again. First and foremost, it is a top priority to keep our seniors safe. However, we've got to recognize that what the real impact of social isolation has been on our seniors, just as we have for our kids who have not been in school. For a full year during the pandemic, I've been heartbroken hearing the stories of seniors who've been isolated, lonely, confused, angry, and sad that they've been separated from their loved ones. In the meantime, they've also been the most fearful of death as well. Our seniors probably have had the hardest among us all. And I know I'm not the only one on this committee that has received hundreds of emails and phone calls and texts from hearing the stories. And I actually got this one just last night from Roxy from Battle Lake, and I wanted to just read it. Dear Karin, my husband is 65 years old and has a disease called FSP. I took care of him from 2000 to 2015 on our farm, at which time he became too much to care for, and we moved into a senior living facility. My husband cannot walk, feed himself, bathe himself, or toilet himself. He's 100% total care. He's a two-person lift, if you will. The great thing is he's sharp and communicates well and is very aware of everything going on. We've abided by all of the rules with this COVID stuff. He actually had COVID and almost died. He was in the COVID wing for 13 days and developed pneumonia on top of it. Family was called in thinking he was slipping away, but he survived against all odds. We have had our vaccine and have done everything asked of us, but this is too much. Please imagine what quarantine looks like. Our routine has been since 2015 to bring him home for visits, for a meal, for a ride around the yard, for some fresh air about twice a week. Ever since Christmas, we've been doing this without quarantine. Suddenly last week, we were told he was now going to have to quarantine for 2 weeks after he chooses to go out for non-essential visits. Please, again, imagine what quarantine looks like. All of his meals are in the room, no movement outside of his room. The door is shut. I'm not able to visit at all. Please tell whoever is making this rule that if it were their husband or wife, is that what you would want at this stage in the COVID game? The mandate needs to change today. My husband is inconsolable. I really feel like you've all forgotten about the effect this is having emotionally on nursing homes residents. Protecting from COVID? When is enough enough? Does my husband have to pay the price again? When you're making your decisions, please remember my husband sitting in his room with the door shut and no visits. I'm asking that you be reasonable and kind. Mandates need to change today. Roxy from Battle Lake. And she's watching today. So we're now at the important juncture in this COVID journey, one which the vast majority of our seniors in the nursing homes and assisted living settings will soon be fully vaccinated if they aren't already, and we can see the light. I realize that I may be a little ahead of the issue and that MDH may say today that they're waiting for federal guidance relating to the specific direction for nursing home, or there may not be high enough levels of complete vaccinations. However, I believe we have to be discussing this now. We need to be planning now. The top priority today is for a plan to safely reunite our families. I'm instigating this conversation today to bring together the Department of Health and the long-term care industry leaders for them both to provide their perspectives, their current challenges, and their plans for the next steps for the committee and the public. As I've said throughout the past 3 months during these hearings, the public needs to have full transparency. We've had the slides that MDH sent over last night. We've had them posted, and I don't know, members, if you've had time to look at them. I'm going to have to dip out for a little bit because I have a bill in another committee. So I just wanted to in case you're at this point in the slides and I'm not back yet, I just wanted to say that I'm not satisfied with the MDH slide number 7 that states that there are ongoing discussions on visitation, quarantine, and vaccine guidance with stakeholders internally. I'd like to hear today what those ongoing discussions are publicly. Also, slide number 13, I'm not satisfied with MDH saying that they are committed to continuing the conversation regarding how broader visitations and non-medical outings evolve. I kind of would like that out too, and some concrete resolutions and continue instead of continuing to have the conversation. And then CMS currently is working on revised guidance for healthcare settings, and MDH remains in close contact with CMS regarding the upcoming revisions. So today, members, I'd like to challenge the commissioner and MDH testifiers to be transparent to this committee and most importantly, the public about what these internal conversations are and what the agency is discussing with CMS about upcoming revisions. What are the specific plans? Because people like Roxy and Battle Lake need to know them now. On Monday, we got the good news that the CDC released guidance saying it's okay for fully vaccinated seniors in the community to visit with their families and in many different scenarios. While the federal government regulates our nursing homes, the state regulates the assisted living and other community-based settings for seniors. Given the vaccination status of seniors in these settings, I believe the agency could make some common sense changes to its visitation and other restrictive policies. Seniors and their families around the state are increasingly asking, and I know you want to let your constituents know, members, what the current thinking is from MDH and the industry at this point in the vaccine distribution. My goal for today's hearing is to discuss what the next steps can be taken to modify any Minnesota regulatory restrictions that the state has control of changing. From my end, I'll do whatever it takes to bring the right people together and help seniors reunite with their families. So that's my soapbox in case I'm missing during that part. But before we get started, today's hearing topic, Commissioner Malcolm contacted me yesterday with news about a data reporting error related to the COVID cases and deaths. So she's here to provide a brief update to the committee on the matter and what happened and how it happened. And again, I encourage full transparency to the public. So Commissioner, I have set aside 10 minutes for that. I hope that's enough. And to hear about that data thing, and then we can roll on into how we're going to get our families back together. So Commissioner, off to you. Thanks.
Thank you, Madam Chair. Yes. Thank you. And good morning, members, and good morning to everyone watching. Yes, I think 10 minutes would be great. This is a very important topic. We couldn't agree more about the importance of emotional well-being for families and residents. And we're proud that we were one of the first to set up the Essential Visitor Program, for example. So we totally share your goals here. On this data question, I'll be really brief, and folks can see the slides at their convenience. So we I think it go to the next slide, please. We continually do quality reviews and data audits to make sure that our data are as accurate as possible. If you'd go to the next slide, please. Not sure who's helping with the slides here, but I'll just keep going, and hopefully the slides will catch up. We care very much.
Commissioner, sorry, it says my screen sharing is paused. So I'm not able to advance the slides.
Okay. I don't know if Susie or anybody else is able to advance them.
I don't see anything from my end that certainly no restrictions have been made. So
okay, let me try again. Let me just see if there's, if I just start again, it will.
Yeah. Why don't you, please just see if we can get them up, and if not, I can just talk it through. We do absolutely share the goal and the commitment to transparency and data accuracy. We are very careful to make sure that the data we post, thank you, there we go, are accurate. So we're continually doing quality assurance work. And in the course of that, our epidemiologists recently were auditing a set of what we consider to be unverified case reports, most of which were from long-term care facilities over the last 5 months or so. What an unverified case report means is that when a facility notifies the department that they believe that a resident or staff member is positive for COVID, we get that we think we have a case report from the facility, but we don't actually get a corresponding lab report confirming the COVID diagnosis. So that then is excuse me, unverified until we get that confirmation of lab results. So we don't put those numbers in our totals until we know that it is a confirmed case. Next slide, please. So we get that usually from the lab report directly their results to the department as they are required to do under the communicable disease reporting rule authorized by statute. So in this case, as our epidemiologists were doing this audit and reviewing these unverified cases, we discovered that that data was not being submitted by, in this case, for labs, for private sector labs. So we notified the labs that they were not reporting as the law requires, and as a result, received about 37,000 test results from those labs that they had not previously reported to us. And we actually made notice last week that we were getting these previously unsubmitted test results, and that we would be reporting on the results of tying those tests out to cases as soon as we could. And that we completed that analysis and were able to do that rest of that data release yesterday. So that's what we want to just make sure the committee is and public is clear on. So next slide, please. So the good news is the vast majority of those over 37,000 tests were negative. However, 891 of them were tied back to positive results. So we then needed to tie those results back to cases. The really good thing is because the long-term care facilities were reporting suspected cases to us initially, every one of these cases got the appropriate care and the appropriate public health interventions at the time. So this is really a data issue. It's not a care issue. So when the facilities said, we think we have a case, we advised them on infection control, isolation, quarantine, made sure that they had what they needed to provide the appropriate care and protections. It was just that the confirmation of the case was awaiting those lab results. So that's kind of just a really important distinction, that this has nothing to do with the care that was the outcomes of the care, but rather the data underlying our reporting. Next slide, please. So now that we've got all that, our staff has worked really, really hard and really quickly to do the investigation to connect the lab tests with the cases. So yesterday, we reported an increase in our total cumulative cases of 891. There were 22 hospitalizations and 138 deaths associated with those 891 cases. So that resulted in what looked yesterday to be a really big bump in those data. But we did flag on the daily report on the web and briefed a few of the reporters that particularly follow these data issues on the amount of those cases that were from this lab reporting backlog. So that represents 0.2% of the total cases over the course of the pandemic, and 2% of the long-term care cases, 2% of total deaths, and 3% of long-term care deaths. Next slide kind of shows you, if you, and we've gone back and correlated these cases to the dates on which they should have been reported. If the labs had reported the data, this is what it would have looked like in terms of the cases. And you can see they're spread out over the last 5 months. So they were all reported as a big bolus, but they really, if they'd been come in as they should have through the reporting requirements, you would have just seen this, these cases kind of folded right into the pattern of what was happening at the time. Next slide, I think, looks at the same thing with respect to those deaths. So attributing that back to the actual date of death, you can see that there was no big spike other than what was associated with that fall surge, so that you can see kind of what the actual dates were, what should have been in the data all along had the reporting been current. So that's just important to know that we recognize that it can be confusing and alarming to look like we're reporting a big bunch of things all at once, but the actual sequence of events goes back over this period of time. So when you factor that in, the increase in our cases and our deaths, you can go to the next slide, please. This just shows, kind of what impact the addition of these cases has on our performance nationally. And you can see, even though that's a big number reported on one day, that it doesn't really change our metrics of deaths per 100,000. We still are, along with Wisconsin, significantly outperforming our regional neighbors here. Next slide, please. So just in summary, just wanted you to be aware of what might have looked like a really odd and alarming result yesterday. It was not that yesterday was a huge day for new cases and new deaths. It was that data cleanup. This is so important to us. It's been a great reminder, frankly, to everyone that this required reporting is really essential to keep the data current and accurate. So we've sent out a reminder. We're talking with these particular labs just to understand the reasons why they didn't report and to assure that they have fully corrected on their end. We also have sent out a reminder to all laboratories, and we have 924 laboratories reporting into us during this pandemic, many times more than would be the regular number of labs reporting communicable diseases to us. But we've reminded all of them that this is really important and that failure to report as required could result in administrative penalties. So we wanted to put this data out there, as soon as the analysis was finished. So that was why we got this out there yesterday. But I did want Madam Chair to be aware of that, and the timing of the committee was great. That I could just make sure that the committee was fully aware of this as well. And I hope that answers questions that you may have had. I don't want to take time away from this important topic, but absolutely happy to answer any questions now or offline that you still might have. Thank you for the time.
Thank you, Commissioner. And I do want to thank you and let everybody know Commissioner Malcolm did call me as soon as she found out yesterday morning. She called and said, hey, you might see a spike on the MDH website. Here is why. Just wanted to let you know. So thank you so much, because that did actually, another colleague here came up and knocked on my office door and said, did you see the MDH numbers? Oh my gosh, what happened? And I said, it's okay, relax. She called me already. So thank you so much. I really appreciated it. Thank you. Members, are there any questions of the commissioner on this topic? Seeing none, I am going to pass the virtual gavel over to Senator Curran. And I got to get my gavel. And then I'll go present, and you can continue on, Senator or Chair Curran. Thank you.
Thank you, Madam Chair. And it looks like on our agenda we have we have a variety of testifiers on reopening of the assisted living facilities. Kind of what's next, and so I think what we'd like to do is move forward with those testifiers. And I think the first one up is Diane Ridrich, Assistant Commissioner of the Minnesota Department of Health. Diane, sorry if I destroyed your last name there, the pronunciation. Please state your name and who you're with. Thank you.
Yes, thank you, Mr. Chair. And I will let you know I am used to it with a last name like mine. So you are not the first and you will not be the last. But for the record, my name is Diane Rydrick, and I'm the Acting Assistant Commissioner of the Health Systems Bureau at the Minnesota Department of Health. So I will provide a general intro and an overview, and I will turn it over to my colleague, Lindsay Krieger, and then we'll circle back to me towards the end of the presentation. And I'll just say, I need to manage Zoom meetings on both my phone and my laptop. So if you see me looking to the side or the camera seems wonky, it's because I have to do the video on my phone and then look at notes on my computer. So I apologize for that. But if we could just go to the next slide. And I would just say to the committee, thanks for having us here today to talk about visitation and long-term care facilities. And it sounds like Chair Housley has had to step out for a minute, but I wanted to note I really appreciate the way that she led into this conversation with the letter that she received. We talk a lot about the impact of the pandemic generally for this very vulnerable population in long-term care, but it really hits home for each individual and each family member in a very personal way. And so it is heartbreaking to hear those letters, but it's important to hear too. So I just want to say at the outset, we know that this is a very urgent issue for residents and for family members. We know it's been an incredibly difficult year of loss and separation and fear for many people. And given how far we've come with vaccination and long-term care in the last couple of months, we know that there's a lot of frustration and impatience that things are not fully back to normal. In terms of the letter that Senator Housley read, if you could let us know the name of the facility, we can follow up with them. But we were having a chat while she was reading it, and it sounds like Roxy should be able to go in for compassionate care visits even now under the current guidance. And that's something that we can clarify with the facility. We do hear questions and hear stories like that quite often. Relatively frequently. And again, they are really difficult to hear. We often do find that there is a misinterpretation of the guidance or a difference in the way it's being applied in a particular facility. So we can clarify that with the facility if we know who it is. And it would be great to have that direct connection. So I just want to start out really quickly by talking about some of the core principles that have guided us over the last year before Lindsay goes to some of the details. Again, we know that this population in long-term care is at the most risk of COVID because of their higher age, because of the likelihood that they face significant health concerns, and because they live in congregate settings where it's more difficult to maintain safe distances. Throughout the response, we've worked to find the right balance between keeping people safe from COVID and recognizing the increased risk that they will contract it, and that if they do, they will have a serious outcome of hospitalization or death. But also recognizing that some of those same measures that keep people safe can increase social isolation, and that impacts people both in a physical way and in an emotional way that can cause harm. Every facility and every community are different. So sometimes what feels right for one facility in terms of how they are managing visiting and congregate dining and other things might feel too restrictive or not restrictive enough in another facility. So there is always some nuance in how an individual facility might manage that balance. But in our guidance, we try to really recognize both. We always look to CDC and to CMS for their expertise and their guidance on best practices for protecting residents and on what that right balance is. Sometimes we get impatient when the guidance doesn't move quickly enough at the federal level, and yet we have to follow it. And we really do look to that as our sort of North Star, even when we get frustrated too. We will discuss here the fact that there are some facilities that are federally regulated and there are some that are state regulated. But even with state regulated facilities, the federal guidance gives us a framework for implementing the practices that are based on the best available evidence at the time. And I'll just note, we also have sought always to provide a wide range of resources and supports to facilities to help them keep their residents safe and to navigate the guidance that's out there, because it can be confusing. And it can be hard to interpret. Guidance might seem clear to the people who wrote it, but there are so many nuances at the time and so many kind of gray areas in how a particular facility implements it. And they need a lot of support to really understand how to do that well. So we provide infection control consultation, we provide staffing support, we provide PPE and education on how to use it appropriately and when to use it appropriately with staff. And we provide a lot of supports on testing and now on vaccination. And those supports that we provide really exist side by side with the regulations and the guidance that we that these facilities operate under. So I'll go to the next slide, which will be a shorter one. Thank you. So I noted a moment ago that we have a mix of federally regulated and state regulated facilities in Minnesota. We'll talk today about nursing homes, which are federally regulated by CMS, and about assisted living or assisted living type facilities, which are regulated at the state level. There are a number of situations where we adapt or adopt the guidance that the federally regulated facilities use and apply it to state regulated facilities as well. And this is for a couple of reasons. One is that it really provides important consistency for family members who might not, when they're thinking about their loved one, they're probably not thinking about who is the regulator for this facility. They just want to know, what's happening on this campus, what's happening in this system, what's happening in this facility. And so where possible and where we think there's value in it, we try to be consistent. Also recognizing that some campuses or even some buildings federally regulated and state regulated components. You might have one wing that is under sort of one level of oversight and another wing or another campus that's under another. want to reflect that recognition that residents in both types of settings are at higher risk from COVID than the general population, and so need that added layer of protection from getting COVID or from becoming seriously ill from it. And so we try and keep that higher risk for both populations in mind when we're thinking about the guidance. So with the next slide, which we can advance to, I'll turn it over to Lindsay Krieger, who can introduce herself and provide more details about the timeline of visiting guidance in Minnesota and on the federal level, and where we're at right now in where we think CMS might be going and when additional guidance may come.
Thank you very much. Mr. Chair, members of the committee, for the record, my name is Lindsay Krieger. I am the
Thank you, Lindsay.
Yeah. For the record, my name is Lindsay Krieger. I am the director of the Office of Health Facility Complaints at the Minnesota Department. As Assistant Commissioner Rydrick mentioned, over the last year throughout the COVID-19 pandemic, we have been working to strike a balance between prevention of COVID-19 infection and ensuring opportunities for healthy social connection for residents in long-term care. I'd like to walk through how the visitation restrictions for long-term care have evolved through the COVID-19 public health.
Ms. Kruger, could you hold 1 second? Other members, are you able to hear the sound clearly? Okay, Ms. Kruger, I'm not sure if you could be closer to your mic or speak more directly into it. It's coming through very staticky.
Okay,
Thank
otherwise
you.
maybe I can see if I can call in here. I'm sorry, I apologize. I tested this like 15 times before we started. Is this better?
Yes, it appears to be better when you're speaking directly towards your mic.
Okay, I will stay right here. Okay, so I'd like to walk through how the visitation restrictions for long-term care have evolved through the COVID-19 pandemic and public health emergency. In the beginning, March 4th of 2020, CMS published federal guidance on restrictions because of the COVID-19 pandemic. Restrictions included canceling of communal dining, canceling of activities, and significantly restricting visitation except for compassionate care settings. With this guidance also came strict instructions for infection control measurements. Now on March 16th, the Department of Health adopted CMS's federal guidance as guidance for MDH's state-only licensed providers, as many of the state's most vulnerable adults live in these settings as well. In early April, CMS published a statement, recommendation, state and local governments and nursing homes, which indicated that providers should be implementing and CMS guidance in their settings for infection control measures, screening for both residents and staff, guidance for use of personal protective equipment, otherwise known as PPE, how to utilize staffing, and also how to cohort residents in the facility. And then just over 1 month later, on May 18th of 2020, CMS published nursing home reopening recommendations for states to use as guidance for determining when and how to allow broader visitation in long-term care settings. This guidance is a phased approach with core factors to consider when moving.
Ms. Kruger? Members, the video or your audio just cut out entirely on the last few seconds. So I don't know if speaking more loudly or clearly after, again, if the location towards your mic, it's been cutting out and it's still very difficult to hear. Is there somebody else who could deliver this information who has better connectivity with your organization?
I apologize. I can go ahead and log in on my phone if that would be more helpful.
I've found, as I do myself, I do my audio directly dialed in from my phone and do the video for the, and it seems to provide more consistent and more clarity for all calls. So if you could do that, that would be wonderful. Members will take it just a second. I think it's worthwhile to pause for a moment so we can hear everything clearly.
Thanks, Mr. Chair, for giving us a moment to try to improve this here.
Yeah, thank you, Commissioner. And I've practiced. I think for everybody, we don't do a very good job at best practices, and it's always best to separate the audio from the video for more consistent and clearer audio. It is one of those things that we haven't done a great job at instructing all participants the way to minimize opportunity or conflict. So, Ms. Kruger, are you? Looks like audio is not active right now. Looks like she's transitioned.
Yeah, I'm wondering, Assistant Commissioner Rydrick, can you, while Lindsay's working on this, maybe pick up and do these next few slides?
Thank you, Commissioner, and Assistant Commissioner Rydrick. That would be wonderful if you could.
Yes, Mr. Chair, let me just get my video back on here and get back in the connection.
Thank you.
So just to make sure, I'm not quite sure where Lindsay had left off.
It's on page four of the current.
She's on, yeah, I'm looking at that. I'm not sure which bullet she had left off on.
I believe she was on the last.
Yeah, she was on the last point, Diane.
Okay, thank you. So, so Lindsay was laying out, Ms. Kruger was laying out a timeline that started in March, where I think CMS was really in a phase of kind of continually modifying their guidance for states and clarifying what activities needed to be in place, what needed to be implemented within each facility in order to stay safe as our knowledge of the pandemic was really evolving. So their reopening recommendations for states were released in mid-May of 2020. If you could go on to the next slide. And I will note my expertise on this is not as in-depth as Ms. Krieger's is. And so I'm hoping that she will be able to get back in and join us soon. So in mid-June, one of the first steps that we were able to take was to develop guidance for window visits. So a process for people to be able to visit a family member while the resident remained inside, and the family members were outside and could visit through a window. I think for a lot of people that was a step forward, but not particularly satisfying as a chance to see loved ones and really acknowledge what we knew at the time about the risk of infection. And the way to minimize that using outdoor visits where possible. That expanded a little bit later in mid-June with outdoor visitation guidance. And I want to ask if Maria King, if you were on the line, would you be able to say a little bit more about some of the details of the outdoor visitation guidance? I think I can only speak to it somewhat generally, and I'd like it if you could provide a bit more detail.
Mr. Rydrick, I think Lindsay shows that she has audio connected. Ms. Kruger, are you able to test your audio at this point? Let's see if she pops on.
Hi,
There we go.
this is Lindsay. Can you hear me?
Lindsay,
Well,
it didn't. Your audio still seems to be a little bit choppy.
Okay. I do apologize. Maria,
Could you try? Ms. Kruger, could you try see if we can, we're on slide 5, midpoint. Let's try your audio.
Can you hear me now?
Okay. Ms. Kruger, I think a portion of it cut out. Try a full sentence or give us a little more dialogue.
This is
with just
Lindsay.
the audio.
This is
That was
this is
better.
Lindsay. Can you hear
Okay.
me now?
We can hear you better. Let's go. Let's try
Okay.
it. Let's move back to Ms. Kruger. Thank you.
Oh, okay. I do apologize. So in June 12th of 2020, we were planning to publish window visit guidance. And I know many of us had seen the touching pictures of loved ones visiting a resident in the center. The guidance that we put out in June gave the opportunity for facilities to work and their visitors to allow window visits to bring safety for all involved. 17th, MPH published outdoor visitation as a means to balance safety with well-being. The guidance gave strong recommendations for facilities to outdoor visitation. Guidance outlined best practice criteria for residents and visitors during outdoor visitation. On July 25th, Minnesota was one of the first states to develop and implement essential caregiver visitation guidance. Essential caregiver would be a family member, outside caregiver, friend, or volunteer who provides regular care and support to a resident or during long-term care facilities were not required to implement the essential caregiver program, but the guidance provided recommendation. Is my sound better or no?
Ms. Kruger, we still are having a very difficult time listening. I think when you speak with the great inflection, it appears to pick up your voice, but when you fade off at the end of every sentence. And so we either need to get that corrected or Commissioner or Commissioner Redrick, can we get somebody to move on or finish that has audio that we can hear? And I think we understand where we've been. If we could move through these fairly quickly, I think members and I think people would like to know what are we looking at for the future. And so I think it would be best if we could roll through this pretty quickly and then talk about where we are. And I assume the slides are going to cover where we're going. So thank you.
Yeah.
Whichever member of your team.
Yes, thank you, Mr. Chair. I'm going to ask Maria King, who is also here on the line, to step in and quickly go through the next couple of slides. Thank you.
Excellent.
And thank you for your indulgence with the technical issues.
Thank you, Ms. And Ms. King, if you could state your name and your position. Thank you.
Good morning, Chairman. My name is Maria King. I am an assistant program manager in the licensing and certification section of the Health Regulation Division of the Minnesota Department of Health. I'll be happy to try and help with getting through this historical guidance here. So I'm just going to back up. In June of 2020, both window and outdoor visitation guidance was published. These were published with an effort to be able to provide safe methods for families and loved ones to be able to communicate with each other again and to have that opportunity to, again, allow for individuals to be able to spend time with one another. On the 25th of July, Minnesota, as Lindsay indicated, was one of the first states to be able to institute an essential caregiver visitation program. This was a non-mandatory program, but it was designed for essential caregivers where they could be able to come in and provide care for their loved one. And it was designed for providers to be able to create a system for families who had been previously involved and engaged in the care of their loved one before and through the pandemic to be able to provide care for their family members. In August of 2020, broader visitation guidance was released, and this was identified in levels. And you'll see on the slide here that in level 1, facilities that had active cases or where there had been an exposure from COVID-19 in the last 28 days could not have that broader visitation. In level 2, facilities who had never had a COVID-19 case or who had not had a COVID-19 case or exposure in the last 28 days and could meet safety requirements could move to that level. If you could advance the slide, please. In September of 2020, CMS, to our surprise, actually came out with a broader visitation guidance for the skilled nursing facilities, which was effective 1 month from publication, so October 17th. And Minnesota at that time adopted that guidance for use in nursing homes. On October 12th of 2020, MDH issued assisted living setting guidance, which we would also implement as of October 17th. Are you able to hear me all right? I can see you look a little perplexed. Okay.
No, we can hear you're coming through loud and clear. Thank you, Ms. King.
Yep, great. This was able to align the nursing home and assisted living guidance where able for consistency. That guidance identified facilities in 3 risk categories based on the county positivity rates of low, medium, and high, and facilities without recent cases in lower medium level counties had to allow for indoor visitation unless there was a reasonable or clinical safety issue, such as a staffing crisis. And then we continued to encourage and for allowing essential caregiver and compassionate care visits without change, because those are things that had already been in place. Next slide, please. Then, of course, the holidays came, and we all know how important it is to spend time with our loved ones. And we sought, we were having people seek direction around how they could provide safe holiday visitation. So there was holiday visitation guidance released in November to December of 2020, and largely that was informed by CDC guidance that was already available. In January of 2021, we had a request for providers, from providers and the provider groups, to have some kind of guidance identified that would address non-medically necessary outings. So how people could leave safely and how those outings could be handled safely. And we did work with our, in the health department throughout the pandemic. We've had our regulators and our epidemiologists have worked together to make sure that we're providing guidance that is provides methods for being able to conduct these things in a safe manner. That guidance recommended visiting with loved ones outdoors at the long-term care community or indoors if the facility met the criteria for safe indoor visitation. And it also provided guidance for when there would be outings to lower the risk of spread of COVID-19. Currently, we are, as are the general public and other members of the provider organizations, we are having ongoing conversations about visitation, quarantine, including vaccine guidance, and we're currently awaiting some additional direction from the CDC and CMS. At present, our nursing homes and our assisted living facilities should be facilitating visitation in accordance with the guidance that came out this fall, unless it's contraindicated. Okay. I just want to point out that there was guidance for nursing homes and assisted livings alike that group activities could be facilitated for residents who had fully recovered from COVID-19 and for those who are not in isolation or observation, having been suspected or confirmed with COVID-19 status. So this has been something that's been in place since May of 2020, that there could be group activities with the appropriate infection control measures in place, including social distancing use and appropriate infection control measures. And then use of a face covering as that was able to be done. Okay, next slide, please. There was also guidance regarding dining, and that actually came out at the end of April in 2020, where long-term care facilities could apply social distancing methods, such as ensuring that residents were sitting at tables spaced appropriately and could have their meals together. And this was only not allowed for those residents who were actually had an active case of COVID. We also made arrangements that there could be a method for those persons, even who were on quarantine, that would be the new admissions or someone that might have, that otherwise needed to be quarantined for the 14 days, that they could also eat in a dining room, just not in the same dining space as someone that was not in quarantine, and that they would also have to apply those other infection control measures. Okay, next slide, please. The people that live in long-term care settings are generally considered at risk for COVID, increased risk for COVID-19. And so the guidance that we've provided in being consistent with CMS and CDC has been to recommend that residents avoid in-person gatherings with persons who do not live with them, and that residents who are currently on isolation should not leave the long-term care setting to gather with others. Next slide, please. The quarantine recommendations that are in place in that guidance indicate that residents who leave the building to gather with others may be required upon return to be subject to quarantine. And I know that this is the part that, of course, we're hearing the CDC is working on some additional clarification for us for healthcare settings. We hope that that will come out soon. Residents who meet the certain criteria should be placed in quarantine for 14 days upon return to the facility, and that is to protect the other people in the building that they live in. Residents who have tested positive in the last 90 days so that they've had COVID would not be expected to quarantine upon return. Okay, let's see. I'm sorry, I lost my full screen here. So I apologize for this. I'm having some trouble. There we go. Okay, as of March 5th of 2020, 86 out of 2,059 long-term care facilities have had COVID-19 cases in the last 14 days. There were 5 counties, depending on the varied data source, that were above 10% positivity, and those are identified on the slide here. Based on that information, nearly 95% of the long-term care facilities in this state would be allowed visitors using the broader description based on that data. I think Diane Rydrick wants to present now, starting on slide 13. Thank you.
Yes,
Excellent.
thank you, Maria, and thank you for stepping in. So I'll just quickly go through the last couple of slides. I know that this is something that is certainly on people's minds right now. Is the CDC that just came out on. So that guidance related to allowable activities for individuals who've been fully vaccinated. And it noted that, among other things, people who have been fully vaccinated can now visit with other fully vaccinated people indoors without social distancing or masks. They can visit with unvaccinated people from a single household who are at low risk of severe COVID indoors without masks or distancing, and they don't need to quarantine after a known exposure if they're asymptomatic. I think one of the things that got a little bit lost in some of the headlines about that is that that guidance was specifically for non-healthcare settings. Still, it was long awaited, and it was a really significant step forward. We anticipate that CMS is going to be releasing guidance for healthcare facilities, for healthcare settings very soon, possibly this week. We have been in touch with them every day about this because, as Maria noted, we know that one of the big pain points is related to situations like the one in Roxy's letter from the beginning of this hearing, where someone wants to go in and visit a loved one and is unable to. We are definitely hearing those concerns. I think a little bit less now because the vast majority of facilities are allowing visitors as they should and as they must. But what we're hearing is a really significant to go for an outing, to go out for Easter dinner coming up, to go home to a loved one's home, the same as being able to go to the store and needing to quarantine after that. So we do anticipate that there's going to be guidance coming from CMS that is imminent on that issue, and we know there's a lot of impatience around that. So, Chair Housley noted at the outset that she was wanting to know more specifically and more transparently what we want to do with that.
Ms. Friedrich,
I think it's important
Ms.
that
Friedrich, Ms. Friedrich, your audio now is also
noted
failing
at the
us.
beginning. We look to CMS and see. Oh. Oh no! I know what I can do. I'm as close to my phone as I can be. Are you able to hear me?
Yeah, but you just fade in and out. So, Commissioner Malcolm, I think you need to work on some of your technology. I think we've been at this year now, but we need to move through these quickly.
Is it any better?
We need to move through these
directly without the headphones.
We need to move through these quickly so we can get to we have two industry testifiers, and I'd like to get those wrapped up to allow 20 minutes for questions. So if we could move through the rest.
Our apologies, Mr. Chair, and thanks for your patience.
Thanks, Commissioner.
Yeah, let me just jump in, and I think we can turn this over to our long-term care leader colleagues. I think what Diane was saying there is we hear you loud and clear that just saying we continue to talk about it is not fully satisfying. I think what we're trying to say is we too are pushing CMS and CDC for specifics about healthcare settings and long-term care in particular as soon as possible. And I think we just philosophically completely share your view that emotional well-being and dealing with the very real consequences of social isolation are a health imperative, and we really do agree with that. I think the balance that we've talked about, and I'm sure the association leaders will address this too, we have to keep our eye on, especially given that the variants, the variant strains of the virus are kind of the new wild card in the situation. So keeping some vigilance really is indicated, but it does makes kind of intuitive sense that the guidance with regard to vaccination status should be more aligned with the current guidance on how people who've been exposed to COVID or had COVID are treated with respect to isolation and quarantine. So I can just assure the committee that kind of what we are suggesting and advocating for with CDC and CMS, I think is aligned with the committee's sentiments here, just with that caveat that the risk of the settings and the wild card of the variants is just also something that weighs on us. So I think I'm not sure. Anne, is there one more slide, and then we can just hand it off to our industry colleagues. So this is just sort of the vaccination update. To Madam Chair's opening point, that particularly on the resident side, we're very gratified by the uptake that we've seen to the vaccinations. We continue to be concerned that with lower uptake among staff, that's certainly an education campaign. We need to address any hesitancy concerns. that the staff may have. But we are making good progress. And we will continue to facilitate and work with facilities to make sure that they're able to vaccinate new staff and new residents as they come in. So as the federal pharmacy partnership is winding down, we will still very much be on hand to assist long-term care and continuing to vaccinate. So I think,
Thank you, Commissioner Malcolm and
Yep.
Senator Putnam. Senator Putnam, what we'd like to do is let's get to our industry. Let's get to our industry testifiers, and then we'll do questions. Okay. Thank you. We've got first up Patty Cullen. Patty, are you there? There you go.
I am.
Please state your name and your organization.
Thank you. Thank you, Chairman Coran and members of the committee. I'm Patty Cullen. I'm President CEO of Care Providers in Minnesota. We're a membership organization whose members provide services to older adults in a variety of places they call home, including nursing homes and assisted living. And I see Senator Housley has joined us back, so I should say Chairman Housley. Care Providers is one half of the advocacy collaboration that you probably know as the Long-Term Care Imperative. And so along with my colleagues at Leading Age, we have a voice at the Capitol together. So thank you for holding this hearing, Senator Housley and committee members. I think we all have the same goal at the end of the day. And the question is, how do we get to that goal? We all are looking forward to a future where visitation between friends and families is available in a safe and planful way, whether it's in the community or in their homes. And I think either Commissioner Malcolm or Assistant Commissioner Rydrick mentioned Easter coming around the corner. We are all hopeful that we have something in place well before Easter. So I think the timing of this is just perfect. We know it's been a long 13 months for everyone. The long-term care providers have really been focused in the last 13 months on protecting the lives of the residents in the danger caused by this perfect storm is what we call it. We have a highly contagious, deadly virus, serious risk just for those living in our settings with underlying health conditions who are in communal settings. And we also halfway through this pandemic realized that the transmission of this deadly virus was mostly by people who don't have any symptoms. So that changed a lot of our practices in midstream. So we first want to acknowledge that the impact of this lockdown has been devastating to residents and their families, and even to the dedicated caregivers who have to see the emotional distress on their residents and their families and have to be the one saying, I'm sorry, when you come back, you have to quarantine because here's the rules. And so it's hard on our staff as well. So just backing up, since the pandemic first happened, we've taken a whole bunch of steps to protect our residents. We were in protection mode to help prevent the virus from spreading and to adapt operations as we learn more about transmission. And we know that all these steps that we've taken have taken their toll. Just the letters you see in your offices, we've seen in person on families and residents, as well as our frontline caregivers. So we wanted to come before you to say we are excited by the successful distribution of the vaccine in our settings. We're excited by every day we look at the situation update, and when the numbers are low in our settings, it's a good day for all of us. We are also excited about the latest news from the CDC, knowing that science is catching up, so that we're looking at the time when the next batch of science says, okay, healthcare settings, this is what you can do. Now, having said that, in spite of our high vaccination rates, we know that we're not 100% vaccinated. We know as we admit new residents, there are still going to be vulnerable seniors in our settings. So we need to move forward with caution. And I also say with creativity and innovation. So I have told folks many times that we're not going to go back to exactly how it was, but it might be that the lessons learned bring us to a place that's a little bit better than what it was in terms of visitation and activities and the like. We've learned a lot of lessons. We know that there's ways to safely resume visitation. We have to continue to watch the data. And we know if there's a big outbreak in a community, if there's not a high percentage of vaccines in that community, we have to be careful. We know that a facility one case is an outbreak by definition. So we have to be, when we look at the one positive case, we have to determine then how does that change the risk levels in our settings. What we have heard from some family members is the confusion when we have to flip the switch. But right now, the data and the regulations require us to flip the switch if the positivity rate is high and if we have outbreaks in our buildings. And so that's a hard thing to understand for family members as well as residents. We also know that we've changed all of our infection control practices, active screening, testing, quarantining, and use of the personal protective equipment, PPE, as you know, are going to be standards that we're going to have to continue to do. We didn't do that before the pandemic. So when I say we're not going to go back to what we used to, those are things that we've learned are good practices that we need to keep looking forward to doing. We know how insidious this pandemic can be. We know it's going to take time to get to the point where all restrictions could potentially be removed. In our settings, remember our members have to do that balance between individual residents wanting to bring in all 18 family members and grandkids to celebrate a birthday, who may or may not be vaccinated, who may or may not be screened, with a collective good. We have to be cautious about what one individual may want and balance it against all of the collective benefit to all those entrusted into our care. So we also know that some of the things we've done in the past, like the really big group gatherings where we're all next to each other singing, right now we know about the transmission of droplets and singing and being next to each other. And we know we're not quite there yet. So there are going to be some changes. We've learned that small group gatherings in spaces that allow for a little bit of distancing works. And even if you're unvaccinated, it works. We also know that we have to be creative in some of the best practices, like using limited space, changing the activities, changing how we do dining even. One of the operational challenges that some of our members have is they have elevators to take people to dining room. And elevators are close quarters. And they used to put as many as they could in an elevator at a time to make sure they got everyone down to dining on time. Well, that's not a good idea to have everyone right next to each other. So we had to think differently about how to implement this. There's operational challenges that have been identified, but those operational challenges aren't insurmountable. We know that we have to figure out staffing changes so that we can continue to screen. And we worked with our colleagues at the health department to figure out how can you screen without having to have a person there and to have a device there so we can screen for some of the COVID symptoms. And so that's one of the innovation things we have worked on. We need to make sure that we don't allow unlimited number of visitors. We have to know who's in our building. We're still going to be doing contact tracing for a period of time. And so just having open doors and any number of visitors, we're still not there yet. Again, we all have a strong will to move forward safely and measured to resume visitation, but we do have to make sure that it's planful and that we use our lessons. So we know our residents have better protection with the vaccines. We are so excited to see the take-up rates and the numbers of vaccines. And I know I'm probably way behind on the list. I can't wait till I get vaccinated. Until we get to the point, we still have to address the ongoing social interaction, and our members are there with you. They have been frustrated. You wouldn't believe the emails I got from the nursing facilities and assisted living that have said, what do you mean the CDC says not in our settings? When is that going to change? So we are hoping that Diane is correct and that we have just a matter of days before we have some change in the federal guidance, which will change the state guidance. We know social interaction is important. It's important to the care we give our residents, the interaction with each other, being able to just sit next to each other and play cards, being able to hear each other, to do bingo games. All of that are significantly important to our residents. Being able to go out with family members and come back without quarantining is a big deal. It's a huge deal for our folks, and we get that. We've worked really hard to keep our residents safe from COVID, and we know that it has come with the risk of harm to their emotional, physical, and mental well-being. And Chairperson Housley has read many testimonies from family members that reflect that pain. We are longing to get back to normal. So we believe we have to begin the process, and I think this hearing is perfect timing to make sure that we stay on the track as quickly as possible to return to normal social interaction. We need to make sure when we ease visitation guidance, whether it's out in the community or within our buildings, that we have some responsible conditions and precautions, and that every senior setting is set up a little bit differently in terms of physical space and staffing and PPE and the wishes of the residents and their families themselves. So we need to look at the lens both of resident safety and kind of psychosocial well-being. And I think my colleague from Leading Age will go into a few more details on that. So I think it's Gail Kvenvold's turn.
Mr. Chair.
Madam Chair, I pass the gavel.
Thank you. Thank you. Thank you, Ms. Cullen. That was very informative. I have some questions, but I'm going to wait until after Ms. Kvenvold goes. So go ahead, Gail. Thank you.
Thank you, Chair Housley, members of the committee. My name is Gail Kvenvold, and I'm President and CEO of Leading Age Minnesota. We are indeed the other half of the long-term care imperative. We also are a membership organization of about 1,000 providers of services to older people across the state, including adult day, home-based services, independent senior living, assisted living, nursing home care, the full spectrum, as we often say. And like my colleague, Patty Cullen, I want to thank you for the opportunity today to talk about this topic. And I agree, the timing is just perfect. As you have already heard, it's almost exactly a year since CMS issued their first guidance restricting visitation in our settings, and it's been a long and winding road since then. And guidance has evolved along with our country's understanding of this insidious disease. The guidance we follow today for visitation and other care practices has been updated frequently to reflect the best practices in infection control and in testing and use of PPE. But the constant in the guidance from the very beginning has been, as you've heard from others, the recognition that our older population in congregate settings face a unique and deadly threat from COVID-19. And in light of that, an effort to create as safe a bubble as possible around those residents by limiting their contact with persons in the greater community, as well as restrictions on interaction with one another within the walls of our communities and anyone who might expose them to the risk of COVID-19. There's no doubt that those early and swift actions to restrict contact saved lives. But a year into this virus, we know all too well, and no one knows better than our residents and our families, that that protection has come with a mighty cost. And that has been the physical separation from loved ones, except in very limited circumstances. As providers and as caregivers to the people who reside in our settings, at the heart of all our services to elders is support for what we call the whole person, meaning not just the health or physical related needs that an individual might have, but our needs as human beings for full and meaningful lives, our emotional and social well-being. And for most of us, that translates to contact with our neighbors and our family and our friends and those people in our lives that we deem our loved ones. And separation from them can literally make us sick. As Patty noted, we've been as creative as we possibly can be to try and combat social isolation. She described some of the creative things that we have done, whether it is outdoor visitation stations and weather that permitted it, or hug curtains, or plexiglass visitation stations. And most certainly, I want to call out the Essential Caregivers Program here in Minnesota. As it was acknowledged, we were one of the first states to put that program into place as an exception to visitor restrictions. But I also want to underscore that we took a more expansive approach to that program than most states, even to the point of prioritizing essential caregivers for vaccination alongside our residents and our families when that became possible. And we have been witness to many a joyful reunion as a result of that program. So on Tuesday this week, as we all know, as we saw, announcing the mounting evidence that vaccines do indeed provide protection, we heard federal officials begin their press conference with these words: "Today, we have begun to imagine what the future looks like when we move beyond COVID-19 and to identify some activities that fully vaccinated people can resume with low risk to themselves. We know that didn't apply to us when it was announced, and we know only too well that the risks of COVID-19 are not behind us, as Ms. Cullen noted. But with growing evidence of the protection that is offered by vaccinations and the wide-scale vaccination progress that we're making in our settings, we also are asking for the opportunity to thoughtfully turn the page, to imagine together what our stakeholders, together with our stakeholders, what the future for visitation in our settings can look like. We know we have to move carefully, and that there are changes we can't make without a broad national evidence-based consensus, but some ideas for further study are emerging in state and federal conversations. I want to give you a few examples. For example, should visitation in our settings be tied to the county positivity rates when we reach the point where the vast majority of our residents and many of our staff are vaccinated? Should a single case of COVID-19 in one of our settings trigger the cessation of visitation for the entire community? Or is there a safe way to manage that risk? Can residents who are fully vaccinated and who leave the care setting for a visit with family members, as we heard in such a heartbreaking way from Roxy at the start of this hearing, in those circumstances, can quarantine be eased when they return if their families and themselves are fully vaccinated? Should state guidance for assisted living continue to be the same as for nursing homes? And under what circumstances could we consider whether it's safe to have them differ? And what should be the evolving role for rapid testing strategies in our settings for visitors and ongoing testing with staff when more and more are vaccinated? And how can we introduce even small practices in our settings that would signal a return to some aspects of life that are dear to us? For example, could we safely create small dining bubbles for fully vaccinated residents in our settings where they could sit together at the same table and enjoy a meal, a simple pleasure that we will never again take for granted? So we're open, we're eager for all discussions about steps that are big or small on what safely turning the dials might look like in our settings. And I assure you, we are hearing every day from our residents and families about how eager they are. I just want to emphasize again, though, that we're mindful of the fact that the decisions about next steps have to involve many players, many stakeholders, both the state and the federal level. And any of those changes must come from the foundation of evidence, from the current and growing knowledge about vaccination and best public health practices, and about maintaining the hard-won gains against the virus that have come from regular testing, screening, and strong infection and vigilant infection control practices, and also the lived experience and point of view of residents and their loved ones. And again, I have in my mind the words of Roxy from the start of our hearing. In closing, I just want to acknowledge the incredible patience and endurance of our residents and their families. We hear them. We are hopeful with them as we see the gains of these last months, and we look ahead to a brighter future. And I also want to acknowledge our incredible caregivers across these challenging past months. And their dedication and resilience and heart. It's been a source of inspiration and grace every step, every day. So thank you for the opportunity to be with you this morning.
Thank you, Ms. Kvenvold. Thank you for coming today. And I want to thank both you and Ms. Cullen and all of the caregivers throughout all of our assisted living and memory care and nursing homes throughout the state. It has been a long year for them too, in addition to our residents. Our heart breaks hearing the stories, but these folks and you have to hear them every single day and actually live it. I can't imagine. So thank you for everything that you're doing. And there is light at the end of this COVID-19 pandemic, and we're almost there. And yeah, the timing of this committee worked out too. but I just have a couple questions, and I don't know if either of you can answer it or Commissioner Malcolm. But when you were talking, Gail, I thought that was a great idea. The the little dining bubbles, so some of the residents can get back together and at least dine together. And Patty, you had mentioned the playing cards. Can they not right now, if you've got 4 people that are fully vaccinated, can they, and maybe they're sneaking off and doing it, but can they, if they are all vaccinated, can they go play cards together?
Madam Chair and committee members, we still have the infection control guidance that plays out here, which means we're still saying masking in our settings, in our communal settings, because the CDC guidance, again, doesn't apply to us yet. So they still say 6 feet and masking as the best infection control practices. So what we are hoping that CMS looks at and CDC looks at for our settings is if everyone is vaccinated, they won't have to wear masks and they don't have to sit 6 feet apart. That would be the difference.
Ms. Kvenvold?
Thank you, Chair Housley. As a practical matter, because of the physical distancing requirements that are still part of the guidance, it very often is that one person is sitting alone at an individual table in order to maintain that distancing. So what I was imagining is an opportunity to actually sit at the same table together if you're fully vaccinated and share a meal.
Thank you. Commissioner Malcolm, do you think there's any low-hanging fruit or any little baby steps that we could make? I know that the CDC guidance is for the nursing homes, but for assisted living for some of these folks, because I know they don't want to step outside the boundaries either. But if there's anything we can do at the state level to say, hey, it's okay if the county positivity rates are this and there are no cases, and like they said too, if one case happens in a facility, yet 95% of them are vaccinated. Is what I'm asking, Commissioner Malcolm, is there anything you think that we could do so the families could say they're starting to get us back together?
Well, thank you, Madam Chair. And let me also say thank you to Patty and Gail. They are such great partners, and just my absolute shared appreciation, Madam Chair, for the caregivers in these facilities. They just have been nothing short of heroic. This is exactly the conversation that you asked for some more visibility into. What are the specifics that we're talking about? We're really interested in those ideas about to what extent does it make sense to think about those current restrictions in light of the vaccination rates. The reason why we've thought it was a good thing generally to kind of parallel the assisted living guidance with the nursing home guidance is because, as we know, in Minnesota, our assisted living facilities and providers have been very innovative. They take on, clients that in many cases aren't that different from skilled nursing facility clients. So we've thought that the consistency was a good thing in terms of clarity and just reflecting the reality of the risk of the population. But I'm interested to hear more of the thoughts about which aspects of the regulations might be, or the guidance, might be more appropriate to vary at this stage of the game. So those are the very things we're talking with the provider community and the consumer community about, is how do we strike that right balance?
Thank you, Commissioner. Senator Putnam, you have a question.
Thank you, Madam Chair, and thank you to everyone who testified today. Clearly, this is a compelling and a really significant issue for lots of folks, and for all of us, actually. To me, I know our focus is on visitation, but that's a function of the larger concern for the general health in a facility. And I was disturbed and shocked to see that only 50% of the staff have been vaccinated at this point in vaccine availability. Clearly, if you have 90% of your 96%, 97% of your facility has been vaccinated, but one staff member brings the disease in, that's unacceptable. And I was grateful to hear Commissioner Malcolm acknowledge this concern and talk a little bit about some public health education kind of needs. But in addition, what is industry doing? Because it seems like that's actually within your capacity to encourage industry, in terms of the industries, to encourage staff to become vaccinated. and sort of your responsibility as well. So what have you done so far in that regard, if you wouldn't mind, Ms. Kvenvold and Ms. Cohen, to just sort of explaining a little bit about your efforts in that regard?
Ms. Kvenvold?
Thank you, Senator Housley, and thank you for that question, Senator. We feel it is our responsibility to help educate every member of our staff teams, all of our residents about the availability of vaccination, the efficacy of the vaccines. We've been using materials that have been developed by our colleagues at the Minnesota Department of Health and the federal government as well to do that. We have shared best practices across our provider community for those who have exceeded the average in terms of vaccination rates and take up by staff. What has worked best? One of the things we're discovering has worked best is one-on-one counseling with individual staff members, listening carefully, thoughtfully to what their concerns about the vaccine are, to why they feel hesitant about getting the vaccine, and then in turn sharing resources for them. At Leading Age Minnesota, we recently secured some grant dollars to have kind of a training program for our staff in our settings to become peer communicators around the efficacy of vaccination and encourage vaccine across the staff community. We know that peer information is really important in making this decision. I would also stress we're early in the vaccination process. When you think back, we really only just began this work a matter of weeks ago. So we're encouraged that we're at the point we are now. Our goal would be to have everyone who feels that they can safely take a vaccine get one. And probably the most important of all is that we're thrilled to see the vast majority of our residents in both assisted living and nursing homes vaccinated, and they are the high-risk population. And for in terms of encounters they might have with staff who aren't vaccinated, please remember that we are continuing all infection control, all PPE, all screening practices, all testing practices to identify those individuals who may not have symptoms but be infected with COVID-19.
And I will just add one more thing to what Gail said is we for the flu vaccine, having a 50% uptake is really good. And so when you think about in the world of vaccines, what percentage is good? We both have signed on to a national campaign to get 75% of our staff, and that's our goal. And so we both are working with CDC on the Get Vaccinated campaign and a few others. I do think the CDC guidance this week will make a difference. So for each clinic that we've had, and we've had 3 clinics as part of the federal program, vaccination clinic, we've seen an increase in staff uptake. The first clinic was so new, without information out there, that we didn't have as many staff as we wanted to. So for each subsequent clinic, we've had a greater uptake of staff. But in our settings, until this week, in our settings, even if they were vaccinated, they were supposed to be, to not be able to gather with other people because they were healthcare workers. They took that exception out of there, which gave them kind of a reason now to get vaccinated, in addition to the fact that they're caring for vulnerable people. So if you think about some of the younger workers we have that outside of our settings, they wouldn't be able to gather with their friends because of the guidance. That changed this week. So we do anticipate that number is going to continue to grow, and we are working on it.
I have a question for, I don't know who can answer it. Are residents and staff still being tested twice a week? Because what I've heard from some of the caregivers is, why should I bother to go and get the vaccine when I still have to continue to get tested twice a week?
Testing frequency depends on the color of their county. So green counties can test once a week or even once a month, depending upon if their building themselves have had an outbreak or not. If we still have a couple red counties. And so red counties mean you have to test every week, which means the community spread is there. And that changes. I mean, we look at that map every week. The color of the counties changes every week. So, and if your county changes, you have to stick with that frequency for one whole cycle, which is 14 days. So in some cases, your county may have gone from red to yellow or red to green, and you still have to test at that high frequency. So we understand their frustration about having to keep getting tested, but it also, I will say, is one of our tools. We know that one of our infection control tools that will help guide us through this whole practice, PPE, screening, and testing. And when we get to the easy testing programs, and it's getting easier and easier, I'm getting pretty good at spitting in a tube. I don't know about other people, but I think the invasive nature of the testing will go away and it will become second nature.
Thank you, Ms. Cullen and Ms. Quenville. Is there, I just, one last question, and then if any other members have any, but is there, what is the communication between MDH and the industry? I know before in a previous committee, we heard that 94% of the facilities could actually open. Is that actually happening, or is there a misunderstanding with the current guidance for assisted living, or is it more about the details of the restrictions? Because I remember it was about 2 weeks ago. I don't know if you were here, Commissioner Malcolm, but that's what, or maybe it was you. I can't remember, but I don't know if you could help answer that.
Yeah, I think we did repeat that in this morning's presentation too. That given the county positivity rates and the thankfully low number of facilities that have had a case in the last 14 days, just on those measures, it appears that almost 95% of the facilities should be able to allow visiting, but subject to all of that guidance that we've been talking about. So I would defer to Ms. Cullen and Ms. Quenville on whether there is good understanding or whether there's more we need to do. I think one of my colleagues mentioned we're always happy to consult with individual facilities when it sounds as though they're not taking full advantage of the ability to have visitation. But I defer back to my colleagues on any gaps in understanding.
Thank you, Commissioner. I don't know if Ms. Quenville or Ms. Cullen, you want to answer that? Yeah.
Chair Housley, we try to clear up any confusion that may be there, both by communicating really regularly with our colleagues at the Department of Health, but also by communicating on kind of an unprecedented level with our members. We each do daily updates to our members on how to implement the guidance in their settings, questions they may have. We each do weekly call-in webinars that usually hundreds of people call into to help address questions. We do what we call a coaching room once a week where providers can bring their questions about how to implement the guidance appropriately in their setting. So we are working constantly to try and ensure that there's a really good understanding of what is possible and address any questions as they arise.
Thank you. And our time is ending here, and I don't see any other hands from any of the members. I want to thank you all for coming today and being transparent as much as you can about what's going on. I'm praying for all of our residents in the facilities and the caregivers. Thank you so much for coming. And Commissioner Malcolm, good luck today at 2:00 when you get your first shot.
I'm happy to share, Madam Chair. I'm going to get the Johnson & Johnson as a way of expressing my confidence in the effectiveness. My healthcare provider called me or emailed me that it was my turn and I could sign up. So I'm really thrilled to be getting the shot today. So thank you for that.
Thank you. All right, we are adjourned until next Wednesday.